So let's move on. That's a nice segue, Roy, into the Pacific trial. This has obviously been an interesting year, and certainly practice-changing data has emerged with looking at consolidation immunotherapy post-concurrent chemoradiation for these patients. And so now you want to walk us through the Pacific trial, the design and rationale and what we found out from this data?
Sure. So the Pacific trial was consolidation, durvalumab, a PD-L1 antibody, after concurrent chemotherapy and radiation therapy for unresectable stage 3 disease. It was a phase 3 randomized trial, 2-to-1 to durvalumab every 2 weeks for 1 year or placebo. It was an interesting trial because it was designed at a time where we were first gaining experience with these agents. We were nervous about pneumonitis a few years back. And so I think it was a bold trial to be giving a regimen, a chemo-RT regimen that induces pneumonitis, and then follow that with a PD-L1 antibody that also induces pneumonitis. I think it was definitely a groundbreaking sort of experience. Nevertheless, the data with this trial was reported out last year and published in the New England Journal of Medicine, and the endpoint of the primary endpoints were progression-free survival and overall survival. This trial's not mature enough for overall survival yet, but certainly for progression-free survival, there was a difference that was statistically significant. It was a number, I think, much bigger than any of us expected. The PFS went from just under 6 months to close to 18 months, just under 18 months, so about a year improvement in progression-free survival. There was also a significant reduction in distant metastases as well. There was actually half the number of brain metastases that developed on the durvalumab consolidation. And I think also, as importantly, we really didn't find any significant excess of pneumonitis or autoimmune AE, suggesting that this was very tolerable.
Yeah, and interesting in that data set, well, one of the things I found interesting was the safety profile. I mean, the pneumonitis rate in the durva arm was around 5%, which right after radiation, I would have thought it would have been higher. Certainly some biological rationale to believe that, but we didn't see that. Some of the other interesting parts of that trial were that it benefited all patients, independent of their PD-L1. It didn't seem to matter. Hoss, you have any comments on that?
No, I think it was very interesting. The only minor comment I would say is that we have data now for less than 25% or greater than 25% PD-L1 expression, but we technically don't know what happened to PD-L1 zeros, for instance. Right. So it's a minor difference there. But I agree that overall, when you look at it, every subgroup benefited from the addition of durva, which goes back to the fact that I think maybe PD-L1 is not really the good marker that everybody thinks it is for these kinds of studies, which is a separate discussion. But I agree. I think
the one group, interestingly, where the confidence interval crossed unity was the EGFR mutant patients, and that was a small group.
Yeah. Right.
And whether they would benefit or not is unclear. Would people feel comfortable with a unresectable EGFR mutant patient getting concurrent chemoradiation, giving them the durva based on this data?
Well, I would give them an EGFR inhibitor.
Okay.
So that was we have to argue, yeah.
But getting back to this, I think that we don't know what the PD-L1 status is after chemoradiation. And it's very likely that after some chemotherapy, radiation, you've inflamed the tumor, you've brought T cells into the tumor, that microenvironment could have changed. In fact, many theorize that could be one of the reasons why this works so well. Of course, we need data. I think future studies probably will include biopsies, but I think that's probably a big part of it. You've inflamed a microenvironment, you have T cells there, and now you're relieving the checkpoint.
I think that this is good proof of concept, potential proof of concept of synergy with radiation and plus or minus chemotherapy. The subgroup of patients that were able to be randomized within 14 days of the completion of chemo-RT actually had a more favorable hazard ratio than those that were randomized beyond 14 days. You're allowed to go on anywhere, from I think 1 to 42 days post therapy, and the sooner you got it, the better you did. And that could be that the patients that had to wait, maybe they had more comorbidities, other things going on. or it could represent true synergy.
Yeah, you stole my thunder there. Just tucked away in the appendix is the subset analysis between the patients who got treatment up to 14 days, a hazard ratio of 0.39. And that's fairly compelling, which gets me back to the question we were asking before about consolidation chemotherapy. So now we have a patient who's stage 3, who's getting weekly carboplatin. Do we now say we don't give consolidation because we got to give the durva right away based on this analysis? Is this something we've had some comments on this in Tumor Board because like Hoss, I've had some uncomfortability not giving consolidation carbo when I'm giving the weekly. Based on this data, I would think that, the sooner the better for these patients.
Well, I think you can definitely argue that now that you have the durva data. It's just that, again, it's one of those unknown pieces based on a large study where, we didn't really drill down to see who got consolidation, who didn't, who got carbotaxol, who didn't. Right. So we don't have that data. But I don't think I would argue with someone who says, after weekly carbotaxol, patient is doing well, I just want to go to durva. I don't think I would have any objections to treating patients like that, given the magnitude of benefit that you're seeing from durvalumab.
Right.
I think the consolidation carbotaxol was more out of habit than evidence, and a little bit of concern. Now, some of those patients got induction chemotherapy, so they might have gotten this in the Pacific trial. So it's really hard to tease out the role, but I think for patients in a precarious position, I feel much more comfortable just moving to durva and dropping the carbotaxol.
And it's important to keep in mind that the Pacific trial did not include consolidation chemotherapy.
Induction, interestingly enough, about a third of patients in each, or 25% got induction, but not consolidation.
So that should reassure people who are thinking about giving durvalumab about not being hung up over consolidation or not. But you can complete chemo-RT, and if the patient is doing well, continue on to consolidation.
I think the only point that I would emphasize in this panel is that we are extrapolating a little bit. Again, we don't have the data necessarily to say that that's exactly what happened, right? We're sort of saying, because we don't know what happened, the chemo-RT part of the Pacific is a little bit of an unknown because, everybody did something a little different. So, but we are trying to extrapolate to say that if you don't give consolidation after low-dose weekly carbotaxol, durva should be just as effective. Given the fact that, as Roy just suggested, it could be because of the inflamed tumor, effect of the radiation. I think it's a reasonable assumption, but we just don't have the data necessarily.
Right, and also chemotherapies, I don't know, I'm not a big believer that you're going to cure anyone with lung cancer with chemotherapy, but I am becoming a bit of a believer you can do that with immunotherapy. And the last thing we would want would be to lose that window of opportunity.
Absolutely.
So I'd say that given the whole, the whole data set, I want to get the durva in as quickly as possible.
Does everybody feel comfortable giving durva at this point based on the data? Are there patients we wouldn't give it to? Are we having insurance pushback? Not to bring too much of a financial consideration here, but is everyone getting this done in their patients?
I'm sure there are patients that we wouldn't want to use checkpoint inhibition, the usual contraindications, pre-existing autoimmune disease, patients who received an organ transplant or have serious comorbid conditions with pneumonitis or underlying severe pulmonary disease. But if you had patients with a good performance status who didn't have any other obvious contraindications, I would say I feel comfortable giving durvalumab.
I mean, my observation is that the uptake has been very strong. At our place, it's unusual to put a drug on formulary that's not FDA approved yet. It's in NCCN. It's probably going to be approved by the FDA soon, but they actually based on this data, agree to put it on formulary, and we've been using it pretty regularly. And in the community, it seems like the uptake is good as well. I guess that one question that I would have is there any role for surgery in stage 3 lung cancer?